Yeah, so I'm going to try and save us a little time. I really just have two things I want to say. So I'll say them, and then I'll say them a couple more times, and then we'll be done. This in part comes from work that I did with Gene Abbott and Jackie Glover when we noticed that the Colorado statute had very thin data reporting requirements. And we started to wonder why, and then we started looking across the country at other data reporting requirements. And I should disclose to start with that Gene Abbott is a supporter of medical aid in dying, physician-assisted suicide, whichever we choose to call it. She would be in support of both. Jackie Glover is opposed, and I spent 18 years at the American Medical Association where I was deeply ambivalent the whole time, and I'm still not sure where I stand. It kind of depends on the day and the person I'm talking to. So the three of us realized that there were research-oriented potential questions that could be asked, and I understand these are just two things. I have a whole talk on why people oppose medical aid in dying, and a whole other talk on the history of the Nazis. So I understand this is really oversimplified. But there are a set of concerns around slippery slopes and erosion of social and medical norms. People who are proponents of medical aid in dying are also worried about things like barriers to access to this novel and one presumes useful service, and that disparities in access are important. On both sides, whether you're for or against, you should be concerned about complications in the process of using this medical service, and things like safe disposal of unused drugs. And what I want to posit, this is message number one, assisted dying is a low-frequency, high-risk medical procedure. Like it or not, that's what it is. And we should start treating it like that within the medical profession and stop waiting for government and the state to tell us how to manage this. When we looked across the country, there are roughly 3 sources of data that people are using. There are physician-sourced data, there are patient-sourced data, and there are pharmacy-sourced data. When you look across Colorado, Oregon, Washington, California, Vermont, DC, and Montana, and you can pretty much ignore Montana because they don't collect any data. There were efforts to try and initiate data collection in Montana, which failed in the legislature. And so as a consequence, no one knows what's going on in Montana. But we're pretty close to no one knows what's going on in Colorado, frankly. Right? Well, we have a whole lot of no's here. And there are some things where, for example, we thought it was kind of important to know what the health system or the hospital was of the physician writing the prescription. Who's writing these prescriptions? No state collects that information. So no one can tell you how many patients had to change doctors in order to get access to this service. No one knows. There are a bunch of others here. I won't go through them all in the interest of time. I'll just say that there are very few data that are collected directly from pharmacists. Sorry, side note, obviously there are other sources of data that are unrelated to physician aid in dying, but which are being used in that context. So death certificate data, not directly related. It's not being collected specifically for this purpose, but those data existed already. These are new data that are implemented and data collection systems implemented in order to implement these laws. And again, in Colorado, we know which medicines were prescribed, and the pharmacist has to sign off that they are the one who gave them the medicine, but nothing else. So no one tracks who picked up the medicine. Patient source data, very thin. Everyone basically, except Montana, of course, requires that a patient fill out a form, request some kind of a written attestation, which basically says what they believe their diagnosis is, and it has to be attested by a witness. We in Colorado do not require that there be any documentation whether the family was informed. No one collects information on whether the patient needed to change physicians. No one collects information on what the end-of-life concerns and motivations are for patients. That may be surprising to you because you've seen multiple instances of people saying these are the concerns that drive patients to use these laws. No one asks patients that question. They ask doctors that question. So all of those studies are what the doctor reports was the patient's motivation. I will leave it to you to guess how accurate doctors are at assessing their patients' motivations. But I think if you look at other domains of medical care, you have reason to believe that doctors are not perfectly accurate in understanding why patients are making the decisions that they are. But no one is asking patients why they do this on any kind of a regular basis outside of research studies. And California, of course, has this final personal attestation of capacity. No one else has that. Fascinating. None of the data from that have been reported yet, so I'm not sure what we will learn from it. Colorado just last week reported its data on the first year of implementation. What we know is that 69 Coloradans got prescriptions written. That's what we know. We don't know how many took them. We know that some of them picked the pills up. We don't know, and because, like in every other state with this law, physicians are precluded from writing on the death certificate that the patient died as a result of taking these drugs, we really don't know how many people took the drugs and therefore died. These are some of the data, and I'm not going to go into this in any detail, but I do want to point out that Colorado, which is a pretty white state, to begin with, 96.4% of people receiving these prescriptions are white. That is not standard across the state. I mean, in Denver, 30% of people are Hispanic Latino. So, so the issue of racial ethnic disparities is quite real. And here I just want to call attention to this. 56% of the prescriptions written in Oregon are for an unusual, newer medication protocol, not for secobarbital, which in our state it runs around $4,000. So this is about $500, but we really know nothing about the complications, about how this is being used. And it's not a simple regimen. This is multiple drugs have to be taken in sequence. It's not a piece of cake to just write this prescription out and send people on their way. So there are a couple features that I think are fascinating about the Colorado statute. And I arrived in Colorado from Chicago the year this passed. So I was not involved in the run-up to this or conversations about it at all. But it's interesting that the Colorado statute only allows individuals to opt out, not organizations. Organizations can opt out insofar as they can say, we will not allow you to take the medicine on our premises. In the same way that you cannot take these drugs in a state park. Some people do, but you're not allowed to. And in fact, if you do, within the law is a provision that allows the state to charge your family for the cleanup cost. So if you decide to go to Rocky Mountain National Forest and take these medications, if your family doesn't clean you up, you will be presumably charged for that. In any event, that means that organizations specifically in the law are not allowed to tell the doctors in their organizations, or the pharmacists for that matter, you're not allowed to participate in this law. So individuals are allowed to opt out, of course, but organizations have a very limited opt-out. And the other thing that's interesting is the very light data collection burden. And I believe both of these were put together as a way to improve access to this service by advocates who felt like this was a valuable service and is a valuable service. So the advocates looked at what was happening, and so we're talking about what has been learned over the years. One of the things that's been learned by advocates is that if you allow organizations to tell all of their employees you can't do this, some organizations will do that, and that will pose a barrier. So that went into the law for kind of obvious reasons and was put there by people, I presume, who wanted to remove that potential barrier to accessing this service. It does, of course, also set up within the legal context a showdown over organizational conscience. And since Neil Gorsuch ascended to the Supreme Court and has written specifically about this issue, I think if this ever gets to the Supreme Court, I can guess how it will go. And it probably won't be in favor of the advocates, but we'll see. It will require a case. The light data collection burden is a different issue, though. And I understand it was seen, presumably, as a barrier to access for reasons that may not be immediately apparent, so I'll just specify them. Number one, and maybe the most important, if you know how ballot measures work in states that have ballot measures. So I grew up in Oregon, where initiative referendum recall was originated. So I'm pretty familiar with this. I was in Illinois for a long time, where it was much less common, but fiscal notes are really important. A high fiscal note will tank a ballot measure because people look at the ballot measure and think this is going to cost the state a whole bunch of money, which means it's going to cost me a whole bunch of money. So the fiscal note on this ballot measure needed to be low, presumably as a way to make sure that it would pass. By the way, it passed, flew through, right? So probably the ballot measure could have had a higher fiscal note, and it might have still made it. But the fiscal note on this was $45,000. So that's what our State Department of Public Health and Environment has in order to do their analysis and reporting on this. I understand that's better than what you guys got, which was nothing. But what that means is that our State Department of Public Health and Environment looks at that $45,000 and says, well, what can we do and what do we have? And what we can do is what is absolutely required under the law, no more. So there is not a lot of extra resource going into collecting data that are not absolutely required in the law. The other two reasons why a light data collection burden is seen as beneficial is that physicians might resist filling out forms. That's possible, although I have not heard that as a significant complaint so far, and that patients might worry about privacy if more data are collected. So ironically, what has happened since the passage of this law is we've been trying to get better data collection, and the people pushing back against it are the very advocates who wanted the law to get into place in the first place. And I find that ironic because, of course, the advocates are the ones who use the data from Oregon and elsewhere to advocate that this is a good idea, that this is something we should pursue. And I think it's very interesting. This is a quote from the Denver Post a couple weeks ago, where Compassion Choices, an organization to which, by the way, I am sort of sensitive. I feel good about the work that they generally do, even if I'm not always on the same side. And it's just incredibly frustrating to me that the messaging around this has been, we don't need to know no more. We already know how this works. We saw it in Oregon, and we're done. We don't need to know anything more. We don't need to collect any more data. So here's a pop quiz. I just added this last night. Where else in medicine do you hear doctors saying, I want the government to give me a protocol and tell me what data to collect? I want the state to tell me how to practice medicine. Where else? That's right, nowhere else. So I'm going to just end with what I started with, which is assisted dying is a low-frequency, high-risk procedure. We, as health professionals, should start treating it as such. It is our responsibility, not the responsibility of the government, not the responsibility of activists, to establish a national registry and to have standard data reporting elements and reporting requirements. This is something that our professional associations should be doing. And why we are not is a topic for ongoing debate, and I will stop and allow that debate to proceed.